Good morning, everyone. Start with today's topic, that is TOS Part 2, wherein we'll be dealing with causative factors and categories of TOS. When you talk about causative factor of TOS, what causes TOS? There are n number of reasons that can cause TOS. That is your muscular, or let it be work acquired posture, or let it be your congenital. Hence, these can be categorized into four main different types of causative factor under the four main headings. Let's look at the first one, that is your congenital type. In congenital type of TOS, first point is cervical rib. Cervical rib is the abnormal rib starting from the manubrium sterni to the cervical spine. This can usually lead to compression of this neurovascular structure passing within the costoclavicular triangle, thus leading to symptoms of the TOS. Coming to the second point, that is your prolonged transverse process. Abnormally prolonged transverse process of the cervical spine can lead to compression of the neurovascular structure passing within the interscalene triangle, thus leading to the symptoms of the TOS. Third point, anomalous muscle. Anomalous muscle is nothing but the abnormal orientation, that is your origin and the insertion of the muscle is at not normal places, also the abnormal structure and function of the muscle. If this abnormality is seen in the muscle or the dysfunction is seen in the muscle, it can undergo with time progression, it can undergo spasmodic changes, thus leading to the compression of the structure passing within the muscle. Coming to the fourth point, scoliosis. When we talk about scoliosis, we know that scoliosis comes with two terms. Concavity, that is the side of the scoliosis wherein all the structures are crowding and the muscles are shortening. Whereas convexity, that is the side of the scoliosis wherein the structures are over getting stretched. If the cervical spine is undergoing scoliosis, on the concavity side, scalene muscle can undergo shortening leading to the compression of the structures passing within it. That is your neurovascular bundle, thus causing the TOS symptom. Coming to the congenitally elevated scapulae. When scapula is getting elevated, there are two things happening. First one, interscalene triangle space reduction. Because the scapula is getting elevated, there is crowding of the interscalene muscles leading to interscalene triangle space reduction, thus causing TOS symptom. Also, scapula has articular linking system with the clavicle at the acromioclavicular joint. Thus, when scapula is elevated, the clavicle is pushed forward, thus leading to costoclavicular space reduction, causing TOS symptom again. Coming to the last point in congenital, that is your fibromuscular band. Fibromuscular bands are nothing but the abnormal banding system formed or seen within the muscle. If these fibromuscular band occurs or are seen in the scalene muscle along with the pectoralis muscle can lead to TOS symptom. Coming to the second point of causative factor in TOS is nothing but your acquired. Acquired are absent genetically or absent congenitally. They get acquired along with their abnormal posture. Hence, the first point in acquired form of causative factor of a TOS is postural factors. Imagine you're working on a table on a laptop which is placed a little higher compared to your normal height of the chair. This can lead to decrease in the costoclavicular space, also lead to forward head motion of the cervical spine, leading to interscalene triangle space reduction, thus leading to TOS symptom. Dropped shoulder. This is seen usually in the weakness of the deltoid and rotator cuff muscle. This can further lead to decrease in the interscalene triangle space, thus causing TOS symptom. Wrong working posture. Let it be your overhead activity or let it be on work on the laptop. Any wrong posture for maintained for a certain longer duration of time can cause to a reduction in the interscalene triangle, also costoclavicular, also costoclavicular space reduction, which can lead to TOS symptom. Heavy memories, usually seen in post-delivery, wherein heavy memories can lead to stretch in the pectoralis minor muscle, which can further cause the compression of the neurovascular structure passing beneath it, thus leading to TOS. Trauma to the clavicle. Trauma to the clavicle. Any trauma to the clavicle or displacement of the clavicle can lead to space reduction of costoclavicular space, thus leading to TOS formation or the symptoms of TOS occurrence. Trauma to the rib or clavicle or cervical spine have to follow the same pathway. Coming to the third point of causative factor, that is your muscular. Tightening or shortening of thoracic outlet closer muscle and weakening of the thoracic outlet openers. Some muscles open up the thoracic outlet, whereas some muscles close up the thoracic outlet. Thoracic outlet openers are nothing but levator scapulae, sternocleidomastoid, and upper trapezius. If weakening of these muscles are seen, this can lead to TOS because overactivity of closer of the thoracic outlet is seen, thus leading to TOS. If tightening of, or shortening of the thoracic outlet muscle, closer muscle occurs, which the muscles are pectoralis minor, lower trapezius, and scalene. These are the thoracic outlet closer. If tightening or shortening of these muscles are seen, that it can lead to TOS symptom. Coming to the fourth point of the causative factor, that is your systemic, wherein we have Pankos syndrome, Parsonage-Turner syndrome, and conditions which can coexist with the TOS, that is your CTS, carpal tunnel syndrome, fibromyalgia of the neck, and shoulder muscles. Coming to clinical presentation. When we talk about clinical presentation, how a patient presents his picture to the clinician or to a physiotherapist in a clinic. It usually varies from patient to patient depending on the compression of the structure. If the compression of the artery is seen, then it is different. Then the symptoms are different. If compression of vein is seen, then the symptoms are different. If compression of nerves are seen, then the symptoms are definitely different. Hence, the clinical presentation varies from patient to patient. Coming to the first point, pain anywhere between neck, face, occipital region, or into the chest, shoulder, and upper extremity. These are the structures where pain is seen typically in TOS. But here, when I'm talking about clinical presentation, I'm not talking which structure is getting compressed. It is just a general picture. Coming to the second point, paresthesia. Paresthesia is abnormal sensation. Paresthesia in upper extremity is usually seen in tears, which is altered or absent sensation, weakness, fatigue, and a feeling of heaviness in the arm or hand. The skin can also be blotchy or discolored, depending on the arterial or venous compression. Sorry, a different temperature can also be observed, again leading towards towards the diagnosis of arterial or venous compression. Fifth point, when you're talking about brachial plexus compression, it is divided into upper and lower. There are C5, C6 upper, C8, T1 lower. When the upper plexus is involved, there is pain in the side of the neck, and this pain may radiate to ear and face. Whereas when the lower plexus is involved, it typically have symptoms which are present in the anterior and posterior shoulder region and radiate down the ulnar side of the forearm into the hand, the ring, and the small fingers. Thus, when the pain is seen in the upper extremity, it is usually lower plexus. When the pain is seen towards the face or the side of the neck, it is the upper plexus. Coming to the next point in clinical presentation. Signs and symptoms are typically worse when the arm is abducted, overhead, and externally rotated, with the head rotated to the same or the opposite side. Coming to the four categories of the TOS.